Hello, I'm Dr. Maria Corcorran from the University of Washington. In this Hepatitis C Online mini-lecture, I will discuss harm reduction approaches to prevent the transmission of hepatitis C via injection drug use. In this talk, I will provide a brief overview of the epidemiology of hepatitis C and injection drug use, as well as the infectious complications that can result as a consequence of injection drug use. I will then discuss the principles of harm reduction and outline two evidence-based interventions, including syringe service programs and medications for opioid use disorder, that have been shown to reduce the risk of hepatitis C transmission, including the risk for hepatitis C reinfection. Injection drug use remains the most common risk factor for hepatitis C infection in the United States, as well as in many other countries across the world. In the most recent CDC viral hepatitis surveillance report, 66% of persons with acute hepatitis C for whom risk factor data was available reported a history of injection drug use in the prior 6 months. Injection drug use is also the main driver of hepatitis C reinfection, and large systematic reviews and meta-analyses have estimated the rate of reinfection to be between 5 to 6 cases per 100 person years among persons who inject drugs. That being said, smaller individual studies suggest that reinfection rates could be even higher. In the past decade, there has been a significant increase in injection drug use across the U.S., largely owing to the opioid epidemic and rising rates of stimulant and synthetic opioid use. In 2011, there were an estimated 774,434 persons who inject drugs, also known as PWID, in the United States. However, the estimated number of PWID rose to nearly 3.7 million in 2018, which equates to 1.46% of the adult population. Given the strong correlation between hepatitis C and injection drug use, it should therefore be no surprise that cases of acute hepatitis C, a marker for incidence, continue to rise. In this graph, which uses data from the CDC's most recent viral hepatitis surveillance report, you can see the estimated number of acute hepatitis C infections in the United States has risen from approximately 10,000 in 2010 to nearly 70,000 in 2020. However, hepatitis C is not the only infectious complication of injection drug use, and persons who inject drugs are at risk for a number of other viral, bacterial, and fungal infections depending on how they use drugs. As depicted in this figure, there are several different clinical syndromes that can result from injection drug use, including wound botulism, tetanus, skin and soft tissue infections, osteoarticular infections like osteomyelitis and septic arthritis, endovascular infections like bacteremia and endocarditis, HIV, and other forms of viral hepatitis, including hepatitis B. Harm reduction represents a practical set of strategies and ideas focused on reducing the negative consequences of drug use. In the context of substance use, a harm reduction philosophy accepts that substance use occurs in our society and aims to minimize the harmful effects of substance use through individual and community strategies that are respectful, non-judgmental, and meet people where they're at. Syringe service programs, or SSPs, are one of the most well-known harm reduction interventions to mitigate the negative effects of substance use. SSPs offer a harm reduction approach to reducing the spread of infectious diseases, including hepatitis C and HIV. These community-based prevention programs offer a range of different health services, including access to sterile syringes and injection equipment, as well as safe disposal of used injection equipment. Many also offer testing for hepatitis C and HIV, vaccination against hepatitis A and B, counseling on treatment and prevention of HIV and viral hepatitis, and referral to substance use treatment, mental health services, and other medical care. The CDC reports that SSPs are associated with an estimated 50% reduction in HIV and hepatitis C incidence, and when combined with medications that treat opioid use disorder, HIV and hepatitis C transmission is reduced by over 2/3. SSPs have also been shown to save lives by lowering the likelihood of death from overdoses, and new users of SSPs are 5 times more likely to enter drug treatment and 3 times more likely to stop using drugs than those who do not use the program. With regards to harm reduction messaging for injection drug use, there are several ways individuals can reduce their risk of infection and practice safer use. When using, individuals will often heat up or dissolve their drug in a cooker. This is typically done with a small amount of water in a mini aluminum cup or a spoon. Individuals will then draw up the drug, often using a cotton ball as a filter. Reusing any of this injection equipment, including the needles, syringes, cookers, cottons, or water, can transmit bloodborne pathogens such as HIV, hepatitis C, and hepatitis B. And it's important for individuals who use drugs to understand that sharing any equipment, not just needles, can place them at risk for bloodborne pathogens exposure. Using contaminated water or a contaminated acidification agent, such as lemon water, to mix and dissolve drugs can also place individuals at risk for infections with gram-negative bacilli and Candida, even if these mixing agents are not shared. Similarly, individuals who lick their needles prior to injecting are at risk for infections with oral pathogens, and injecting through an uncleaned area of skin can place individuals at risk for bloodstream infections with common skin bacteria such as staph and strep. Syringe service programs typically offer all of these materials free of charge and are a great resource for patients who use drugs. The North American Syringe Exchange Network, or NASIN, maintains a directory of syringe service programs across the U.S. SSP program locations and hours of operation can be found on their website, as well as other information about SSP services. This directory is free to the public. To find out if there is an SSP in your area, visit www.nasin.org. Medications for opioid use disorder are another evidence-based intervention that can help minimize the risk related to injection drug use. These medications, including buprenorphine, naloxone, and methadone, have been shown to reduce the risk of acquiring hepatitis C in people who inject drugs, likely by reducing overall non-prescription opioid use, as well as injection drug use, and reducing sharing of injection equipment. Medications for opioid use disorder have also been shown to reduce the risk of overdose death amongst persons on treatment, and because of these proven benefits, it is important that providers discuss these treatment options with patients and initiate appropriate treatment plans or referrals. The two most commonly used medications for opioid use disorder include methadone and buprenorphine, which is the active ingredient in drugs like Suboxone, Subutex, and Sublocade. Methadone is a full opioid agonist prescribed and dosed through highly regulated methadone maintenance programs where patients typically go to receive daily dosing. While there are many formulations of methadone available, most methadone clinics use the liquid formulation. Buprenorphine, on the other hand, is a partial opioid agonist that can be prescribed like other prescription medications in an office-based setting. Buprenorphine is most often co-formulated with naloxone in a drug known as Suboxone and administered as a strip or tablet that is dissolved transmucosally in the mouth 1 to 3 times a day. While naloxone, an opioid antagonist, has very little bioavailability when given transmucosally, the addition of naloxone to buprenorphine is meant to discourage individuals from crushing the tablets and dissolving them for intravenous injection, or dissolving the soluble films for injection. The decision regarding which of these medications for opioid use disorder to use in an individual patient depends largely on patient factors, including patient preference and availability of methadone and buprenorphine prescribers in an individual community. While providers used to be required to complete several hours of training and apply to the DEA for an X waiver prior to being able to prescribe buprenorphine, these requirements are no longer in place, and all practitioners who have a current DEA registration that includes Schedule III authority may now prescribe buprenorphine for opioid use disorder in their practice if it is permitted by applicable state law. To learn more about hepatitis C, please check out our online hepatitis C curriculum, which contains a variety of lessons, cases, and slides to reinforce your knowledge. Thanks for joining me today.
The production of this Hepatitis C Online mini-lecture was supported by funding from the Centers for Disease Control and Prevention.